In our AMAB individuals, prostate cancer is extremely common, second only to non-melanoma skin cancer in incidence, and second to lung cancer in mortality. Its lifetime risk is about 16%, but only around 3% of AMAB individuals die from it, highlighting a large prevalence of slow-growing cancers. Many cases, therefore, are clinically silent, with autopsy studies showing high rates of unsuspected prostate cancer in older individuals. PSA or prostate specific antigen is a glycoprotein produced by the prostate's epithelial cells. Although it's widely used for cancer screening, it's not a cancer specific marker. PSA can rise with prostatitis, BPA, benign prostatic hyperplasia, inflammation, prostate manipulation, ejaculation, or even trauma from cycling. Therefore, it's important to recognize also that 5-alpha reductase inhibitors like finasteride cut PSA levels in half, which must be accounted for when you're interpreting results. Due to the limitations, PSA must always be evaluated in clinical context rather than just alone as a standalone diagnostic tool. Now, it used to be that we regularly used PSA as screening in all AMAB individuals, and it's still not completely invalid to consider that so. But as of right now, no major organization recommends routine PSA screening for every AMAB individual. Instead, it's emphasis more on shared decision making between doctor and patient. For example, the USPSTF specifically advises against screening in individuals over 75 because the risk of identifying a cancer and potential treatments and outcomes from those treatments outweigh the benefits. Most guidelines recommend beginning the conversation of to screen or not to screen around 50 years old or earlier in a high-risk individual. This can include patients um, who have a strong family history, who have a strong family history of hormonal-based cancers. So it really will depend on the individual, and it should be a discussion between patient and their provider. One of the biggest challenges with PSA screening is overdiagnosis, in that up to 75% of biopsies triggered by an elevated PSA actually don't reveal cancer. Biopsies aren't benign. They do carry risk of infection, urinary retention, and bleeding. And many detected prostate cancers are indolent and would never cause morbidity within the patient's lifetime. This leads to unnecessary anxiety and or treatment-related complications. This is why PSA screening remains somewhat controversial. So let's looking into how PSA levels can correlate with risk. But again, these are probabilities, not absolute kind of values or numbers to lean into. A PSA under 4 does not exclude cancer. About 15% of individuals with a PSA below 4 will still have cancer on biopsy. A PSA between 4 and 10 carries about a 25% risk, and a level over 10 raises the risk to over 50%. These ranges do help to guide whether additional testing like an MRI or biopsy would be warranted. Now, to improve PSA's accuracy, several adjunct markers are being studied. PSA density normalizes PSA to prostate volume. PSA velocity looks at rate of change over time. And the percentage of free PSA helps differentiate from benign to malignant processes. Cancerous prostates tend to produce more bound PSA, so a lower free to total ratio suggests increased cancer risk. While promising, these measures are not uniformly adopted and not a part of standard screening recommendations at this time. And now, kind of that's our PSA discussion. We're then now going to kind of course back into looking at our AFAB reproductive access and what that indicates in individuals.